So today I'm going to talk a little bit around the need to simplify and continue to simplify models of care for hepatitis C. I'll be focusing really on a case study or one of our pilots at the Burnet Institute led with 3 community sites, focusing on simplifying hepatitis C testing, but really the aim is to try and get people onto treatment and make it easy and get them cured. So I am an epidemiologist, so I can't help but talk a bit about where we've come from and a bit about the data. So where are we on the road to elimination? We have now universal access to DAAs, and thankfully we've got multiple regimens that really help provide options for clients and practitioners to make the best choice around which treatment will work for the client. We have great guidelines that support widespread prescribing patterns, so we've got specialists, GPs, nurse practitioners, hopefully nurse-led models are going to become more popular and more popular. And between March 2016 and June 2017, an estimated 43,000 people were in treatment initiated in that period. However, we do have a slight concern where we're getting a bit of a stagnation in terms of treatment numbers. So they're not falling, but they are stabilizing. And our concern is they'll stabilize at a point where it actually will rebound and we'll end up not eliminating, but we'll get a recurrence of hepatitis C and an increase in epidemiology. So we really want to consider, we're really at this critical point now where we can hammer home treatment and get people onto treatment quickly, and what will end up is hopefully a road to elimination. And I think the next 3 to 5 years are really critical in making sure we can actually get to that point. Models suggest, so mathematical models that use a lot of the data that is coming out of Australia, since we really need to scale up treatment to people at highest risk of transmitting. So this is what Martin and a few other people were highlighting, but that's people who inject drugs. This is what the treatment numbers look like. So as you can see, we were doing really well at treating all the warehouse patients. And at the moment, we are kind of sitting on that 2,000 to 3,000 mark. And unfortunately, our modeling says that may not be enough. So we need about 20,000 treatments a year. Sorry, that was 2,000 to 3,000 per month. So annually, that's about 20,000. But we need to stay at that 20,000. So if we continue to dip, we probably won't hit our elimination targets by 2030. And that really means that we won't probably have cured everybody of hepatitis C. So some of the ongoing challenges in terms of some of the structural barriers, we know that the multi-stage process that a client or user has to go through to get tested and onto treatment is a barrier. You can see here by this diagram, it's usually 1 to 5 visits, really, to get somebody onto treatment. And if you can minimize it, at best you can get 2, which is great. And some nurse-led models are really helping to reduce those numbers of visits to 2. But if you're not doing things like reflexive testing, if you're not following them up and making sure that they can get their liver fibrosis assessment on the day that they show up, if you have to refer them out to another service, it does end up looking like this kind of 1 to 5 visit appointments. We know additional social and structural barriers means that people who inject drugs remain underdiagnosed. They also remain undertreated and poorly engaged in healthcare. And Rob did give us some insights into the reasons for why he may not have been accessing healthcare for a while. It took him a while. So really, we do want to be able to simplify a lot of the models of care so that when someone like Rob does walk through the door, it's actually relatively easy for him to feel certain about taking up treatments and that it's going to be good for him. And hopefully he can get through this process without too much delay. So there have been a number of advancements in terms of diagnostics and point-of-care testing for hepatitis C. Here are some examples that I'm not going to go through in a lot of detail, but we've got some rapid antibody tests now that are WHO pre-qualified, also available for purchase, and we were doing a small pilot where we used this particular antibody test, get a result in 20 minutes. Then there's now rapid point-of-care tests for RNA, so PCR tests. They're not so rapid, they're 120 minutes for a result. So if you're thinking about how we can utilize these sort of tests, having someone wait in an NSP for 120 minutes is pretty damn ridiculous and just unrealistic. So the rapidity of some of these tests are probably not at a point where they are going to simplify our models of care. I'm talking a little bit about a small pilot of rapid testing that we did in Melbourne late last year. The aim were really to assess the feasibility and acceptability of providing rapid hepatitis C testing in community-based sites, but really through the NSP service. So that's what we were targeting. We selected 3 primary health enhanced primary community health centres with NSP, busy NSP, so that was Healthworks, Interspace and North of Richmond. And the model of care that we had NSP, we had trained NSP workers, community health workers and nurses to be doing the testing. We had on-site rapid testing with potential for same-day results. As I said, it was 120 minutes, so kind of unrealistic. And we offered everybody confirmatory testing and follow-up and access to treatment. This was us doing some training around the actual testing kits. You can see here, we did, everyone had to have done a number of tests. I think we had 4 or 5 before they were then able to do the tests in the field. So we had everyone come over to the Burnet and we did a lot of training in terms of getting people really familiar and comfortable with the actual technology. We then had this bit of a complicated pathway. When I say simplify models of care, you can see here, it's not easy to simplify models of care because inherently sometimes they are a bit complicated. And when we're introducing a new diagnostic that hasn't been TGA approved in Australia, we do have to make it a little bit complex to ensure we're complying by some of the regulations. So we had initially a client of the NSP would get offered an opportunity to have a hepatitis C test right now, right there. They were then given an antibody saliva test, so that was a result in 20 minutes. Then they were asked to do a risk assessment and provide a blood sample for a PCR RNA test, which is also rapid. This is the little machine. It fits 4 little cartridges in, so you can do 4 tests at the same time, and a result will be available in 120 minutes. So all in all, for one client, it took about 2 to 3 hours. So as you can imagine, getting someone to hang out and wait for your results is not very fair. I mean, I wouldn't wait that long for a result. So actually what happened was a lot of people kind of left and said, I'll come back for my result or call me later. This is what it looked like in the actual service. So we had people kind of posters promoting it at each service. People could walk in and the NSP workers or the community health workers did the initial oral swab. And then there was a blood collection and you kind of had to sit around and wait for the test result. So all in all, we actually recruited 175 people into our pilot. In the end, 174 went on to have the antibody test. Of those, 150 were reactive or positive, and 140 went on to have their RNA rapid test on site. So it's important to note here that there were 10 participants that we weren't able to collect a blood sample. So either veins were probably not in a state that we could collect blood, or we weren't able to withdraw blood that day. Interestingly though, we ended up going through and follow-up appointments. We had 104 of the 140 participants came back for their second result. So in terms of thinking about simplifying models of care, they had all their diagnosis in one day potentially, and 74% of them came back for their second visit. We did aim to have at that second visit an appointment with a nurse where they could go through all of their bloods, their confirmatory tests, and almost get them onto treatment. So that's what we were aiming for. But in reality, it did kind of probably take a little bit longer than that. I think it's interesting to note that actually of the 74% that came back for their follow-up visit, the median was 11 days. So that's a pretty quick turnaround. So from their diagnosis, 11 days later, most of them came back for their second visit where they could actually have treatment, a treatment script provided to them. In terms of who we reached, essentially this is just to show who the kind of demographics of the population. We actually had quite a few that were living in unstable accommodation or homeless. So we're thinking about who we're reaching with this service. We had almost 20% that were Aboriginal and Torres Strait Islander populations or background. All of them were injecting in the past 6 months, but also a lot of them had been on and off OST. Previous incarceration history was also high. So this is, again, just to note that the population we're reaching with this NSP model are really those high risks and probably very marginalised populations. In terms of their preferences for testing, well, I think it was varied. So a lot of people did like the idea of a rapid test, obviously, and something convenient like 20 minutes, but 120 minutes just was not convenient, and it wasn't rapid enough for most clients. The main reason for testing preferences, a lot of them did say, look, same-day diagnosis is a great thing. Having an accurate test is obviously really important for them. So that's something that we need to be listening to as a sector. And avoiding having blood taken was also an issue for quite a few participants. The main barriers for testing. Interestingly, the main barrier was nothing. Actually, I don't have a barrier to testing. And I don't avoid testing. But other things do get in the way. So busy, other priorities, a lack of motivation. And interestingly enough, when we unpack this a bit, a lack of motivation was really around the lack of urgency. So why should I get tested right now? Or why should I get treated right now? I know there are treatments, and when I'm ready, I'll get them. But I'm not going to drop dead tomorrow. Sorry for the example, but that's kind of what they were thinking. I'll get it when I come back. I'll get it when I'm ready. In terms, we did some qualitative analysis. We did some interviews with clients and with providers to kind of hear about what they were experiencing with the rapid testing. And the major themes that emerged were, one, that the clients really liked being offered testing in the NSP by the NSP workers. They felt like this reduced a further barrier. I don't have to walk around and go make an appointment and register myself at a clinic. I actually can just talk with the worker that I've already got an existing relationship. And that was really important to clients. That rapid test was easy and comfortable, but it wasn't the only important factor in their individual decision-making around when and how to access testing. So while convenience was important and avoiding venipuncture was important, actually ensuring that people could have their bundled HIV test was really important as well. So they don't want to just have a Hep C test, they also want to check the HIV as well. And that currently the rapid RNA tests were not rapid enough. That was very clearly echoed by the staff and the participants, and we kind of knew this already. In terms of some quotes, again, very clear acceptability of rapid testing by NSP staff. So I won't read out the quotes, but really it was felt that clients really enjoyed having to talk or being able to talk to somebody that they knew and felt comfortable with, that they didn't feel judged, and they could ask questions about hepatitis C and treatment. That also there was this kind of probably scale around people's decision making that yes, they want convenient testing, but at what cost? Now, whether it means that they miss opportunities to have their bundled HIV test, well, maybe that's not what they want right now. Where for other clients, not having to have blood taken out of their veins was their priority. And so the motivations around people's decision making about when and how to access testing, it was really varied. And the rapidity, we know 2 hours is way too long. So we're working on this, and the new diagnostics that hopefully will be released in July is an hour, and it's a finger stick. So that's, again, significantly reducing the time to wait. An hour is still a long time. But the kind of, I guess it depends in what setting. If somebody's accessing a service for their general health care, they may wait an hour. So you may be able to fit this in with the model of care, just depending on what else is going on with that client. So in summary, from the Rapid EC study, really conducting point-of-care testing in community clinics with NSPs was feasible and acceptable to clients and to providers. But the NSP was a really useful setting to engage new clients in hepatitis C. That the current rapid point-of-care tests were probably not rapid enough or convenient enough. And that really staff felt that it was a useful tool to engage clients in. It's something new to talk about. You know, there's a new rapid test. You want to get tested. Something new as opposed to some of the old kind of messages that you're trying to push out and it's not really working. So just another kind of tool in your kit to use to engage clients with. So in summary, really, how are we thinking about simplifying Hep C testing? How are we thinking about simplifying Hep C models? And how are we thinking about all the other ongoing challenges that we have? We know that continuing to reduce or address stigma and discrimination is a huge issue, as we heard from Rob. And that increasing awareness of the treatments and promoting some of the benefits of treatments, I think, is really important for the clients. I think that the NSP space is a really exciting space. And this is some examples of the lovely work that Shirley at Braybook has been doing. She's been creating her own stickers for fit packs and also for the syringe tubs, sorry. We've also got some posters and some business cards that are really trying to create a safe environment, an environment where clients can talk about, ask questions, feel accepted to talk about their hepatitis C and NSPC. Acknowledgements to everyone that helped me with slides, particularly the lovely images that Shirley shared with us. And that really the elimination is the goal for everyone, so just keeping an eye on the long-term target.